Good morning, everybody.
Good morning.
Good morning. My name is Ellen Solaris. I'm the current president of the Minnesota Public Health Association, and I am thrilled to be here with you all, the folks in the room, the folks joining us on the live stream, for our first in-person policy forum, I think in 3 years, right?
It's been a while.
It's been a while, but the policy forums are such a staple of MPHA programming, and I'm excited about this opportunity to be here with you all. Today is our first policy forum of the season. The series is Safety is No Accident, Public Health Approaches to Injury Prevention, and we're starting off at home. I have the great privilege of reading our ancestral land statement and then introducing our moderator. The ancestral land statement is also available on the printed agendas or on our website if you would like to also reference that. All right. We ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a long-standing history and connection to the land since time immemorial and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and U.S. governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors, and descendants, as well as the land itself. And I will also say that we freely offer and encourage folks to adopt and adapt this land acknowledgement for their own purposes as well. And now I have the privilege of introducing our moderator, Ken Bence, who, we were tight when I started doing MPHA. We did all sorts of stuff together, so I'm really excited to be here with you. Ken is not only a past president of the Minnesota Public Health Association, but he is the Director of Research, Analysis, and Policy for the Association of Residential Resources in Minnesota, a nonprofit that is dedicated to leading the advancement of home and community-based services supporting people living with disabilities. In that role, he's responsible for creating and maintaining data systems that support their legislative agenda and advocacy efforts. He has served on several boards, and he has over 20 years experience as a paid on-call firefighter and is the current battalion chief with the Golden Valley Fire Department. So he brings in a lot of perspectives to this conversation. I will pass it off to you, Ken.
Thank you very much, Ellen. And welcome to everybody. For those of you watching online, the room here is packed, and so we're glad to be back in person finally. And it feels like it's been a long time since we've been able to gather in person. Those of you here in the room, you don't have to worry about am I on mute or not. So you're not. So please keep your conversations to a minimum while you're sitting here. We're going to do this. For those of you who may know me through various public health connections, this is probably new to see me in this getup, but I thought it was appropriate to wear my fire department uniform today, given our topic. As Ellen said, I've been with the Golden Valley Fire Department for 23 plus years, and so this is almost a dream come true for me to talk about a topic that brings together both public health and public safety. In fact, I had as a tagline on my LinkedIn account for a few years something to the effect of promoting innovation at the intersection of public health and public safety. So this is very much along the lines of something that I'm very interested in. Today happens to be National First Responders Day. Did you know that?
No.
That's what Google told me this morning. So that's a nice coincidence. I hadn't known that before. So I was thinking about this and thinking, what do public health and public safety have in common? I think both of them come at their work with a prevention mindset, so there's a lot of prevention work that happens. Both are concerned on how to provide the greatest good for the greatest number of people. And in both, messaging, communications, and access to good information are very important to get the messages out. So, as a test to the success of some messaging, let me try something. I'm going to start a sentence, and I want to see if you can finish it, and just shout it out if you can. So let's try this. Change your clocks.
And your smoke detectors. No.
There we go. There we go. Change your clocks, change your batteries. That's one of the statements or the messages in fire service. We want to get. It just so happens that not this weekend, but next weekend on November 6th is when we change our clocks again. And so we're going to fall back. So change the batteries, or at least check the batteries on all of your detectors. Smoke detectors, carbon monoxide detectors, okay? Let's try another one. Close before you
Doze.
Hey! Close before you doze. Did you know that if you have your bedroom door fully closed and there's a fire somewhere in your house, the likelihood of your bedroom being impinged by fire decreases dramatically? So a good message is when you go to bed, close your bedroom door. That door is a great barrier. So we have some more work to do, I think, on the messaging. That's a good illustration of that anyway. I came across a great example of public health and public safety working together just last week. Just so happens that Amanda and I were both up in Duluth last week for the State Fire Chiefs annual conference. And I attended a presentation that was a very good illustration of this. The St. Louis Park Fire Department, which is a bordering neighbor of Golden Valley, has worked together with Park Nicollet Methodist Hospital. They've created what they call their Community Health Alliance, and it's been in place for several years. It started as a way to use trusted community resources, so firefighters working on shift, to follow up with people after they were discharged from the hospital to help prevent them going back into the hospital. So those of you in healthcare are aware of this effort to decrease hospital readmissions, and hospitals are held responsible for readmissions that happen. And so this community partnership was started, and what they did is firefighters who were in the home, that was also an opportunity to do a real quick safety survey, safety inspection, looking for things like, are the smoke detectors or carbon monoxides working? Are they present, first of all? And then, are they working? Are there trip hazards that they can help the person mitigate? And are there overloaded electrical circuits? We see that a lot of times when we go in home. So it was a great opportunity to take advantage of that face-to-face time. Well, over time, that program has expanded so that now they also have the opportunity to make referrals to social service or local public health, public safety. The person's needs are such that they would benefit from some other kind of community resource through the social service, public health system, or healthcare system for that matter. Behavioral health are big concerns. They can make those connections. I've provided an example that other fire departments can follow to create these kinds of community connections. So that, to me, seemed like a really good illustration. So as Alan said, this is the first of this new series of. She is the chief deputy state fire marshal, working in the state fire marshal's office in the State Department of Public Safety, and so we're glad to have all three of you here today. So the panelists are each going to give some remarks on their perspectives and their organization's perspectives on our issue of safety in the home today, and then we'll begin some questions. So why don't we start right here with you, Dawn?
Thank you, Ken. Can everybody hear me? Yes, thank you, Ken. Thank you so much. It is just such a pleasure to be here with you this morning, and I was struck in the instructions to panelists that, I believe it was Angie said, we really think of home as haven. And for older adults, and I'm going to speak to issues primarily of falling in the home related to older adults. Home is haven, and older adults are, they fiercely want to hang on to the ability to live in their homes, right? That is just a given, and we need to work hard to help older adults maintain that desire and be able to fulfill that desire, but to help them do it in ways that will keep them safe. So I'm Dot Simonson. Trellis is a private nonprofit organization, but we're designated by the State Unit on Aging, the Minnesota Board on Aging, a relatively small state agency that administers a federal program called the Older Americans Act. We're one of about 650 area agencies on aging in the country. Wherever you might reside, there's an area agency on aging that has a role in assisting older adults to live independently at home. Our focus is about older adults living at home, living in community, and our role is to develop a system of supports to make that happen. We do that in a very small, limited federal budget for the most part under the Older Americans Act. One of the services that we offer is one that you may know, and it's called the Minnesota Senior Linkage Line. So the Metro Area Agency on Aging, along with the other 5 area agencies on aging, are partnered with the state of Minnesota, with the Minnesota Board on Aging, in partnership with Minnesota Department of Human Services, and we operate the Senior Linkage Line. So that is a public service that is available on a call center basis, also some ability to text and chat, and helps older adults find services, helps family caregivers find services. We help explain public benefits. Right now is a very hot time on the Senior Linkage Line because it's the Medicare open enrollment period, and so many people who are on Medicare or who are new to Medicare are calling for help to choose a supplemental plan or a Medicare Advantage plan. So we are basically an organization, again, focused on older adults. And we do our work through 2 organizations, our main nonprofit organization, and we also developed a nonprofit subsidiary where we use our nonprofit subsidiary as a laboratory for innovation, particularly on the issues that I'm going to address today. So my focus on fall prevention comes from the fact that more than 1 in 4 people age 65 plus fall each year. And Minnesota ranks 4th. We have the 4th highest fall rate in the nation. And it's not so much that people are slipping on the ice and snow, but the ice and snow in our long winters keep people at home, and people are more sedentary, and so older adults lose muscle mass, they lose strength. And they also become fearful of falling, and fear of falling is actually a predictor for falls. So this is a very serious issue. Age is a risk factor for falling, and the conditions that come with age are risk factors, including cognitive decline, as well as development of chronic diseases. So what we know about falling is in the home is that over 60% of falls that require a hospitalization happen at home. I think what's so interesting is that men tend to fall outside and in the garden, and women inside. Although perhaps that is perhaps not in my experience, not true, but that is what I understand. And we know that falls can be life-changing and lead to death for older adults. So when we think about a fall, of the 60% that are hospitalized, 60% of that 60% who are hospitalized end up in a nursing home, either permanently or for rehabilitation. 11% suffer a traumatic brain injury, and 27% a hip fracture. And I have lived this with my mother-in-law over the last several months. We saw her, she lives alone. She's starting to become frail over the last winter. We had a family member who lives relatively close. She's in the Fargo area, who would check on her almost daily and help her remain independent at home. But we saw a decline in her cognitive status and definitely decline in her strength. And this, early in the summer, in the spring, huge gardener, outside in the evening, tripped over the downspout and tripped and dislocated her shoulder. And that led to surgery, and she is finding herself really, because of a whole variety now of cascading issues, with a very permanent disability on her main arm and hand. Her cognitive status has declined tremendously. She's depressed, and she is losing weight, and we've just helped her transition to a nursing home. So this plays out each and every day with older adults, and there are measures we can take in the public health and aging community that can change this trajectory for older adults. Now, when we think about homes, the environment is really a factor. So stairs, a major factor. If somebody lives on a main floor, that is, and can avoid stairs, that's very helpful. Bathrooms, lots of people fall in the bathroom. Driveways and sidewalks, that's where the fall on concrete or pavement often leads to a traumatic brain injury. So this rather grim picture also in terms of kind of human suffering also is a very negative picture when we think about the cost, right, to our public programs. So 95% of hospital charges for older adults are related to falls are billed to public programs, either a Medicare program or a Medicaid program. And the annual cost is $1.7 billion in hospital costs and about $145 million annually in outpatient emergency department charges. So this is an area that is well understood. And I think part of the opportunity here, and I will describe some work that we're doing, is that older adults, they understand falls in a way that I think sometimes they may not quite understand may not understand a chronic disease that could also be very life-changing, right? There's this sort of natural fear of falling. It's very clear, it's very tangible. You fall, you have a fracture. You fall, you have a traumatic brain injury. And they see people in their friends' circle or neighbors or others suffer a fall and see the consequences. And so for several years, we have been focused on the policy conversation at the national level around the social determinants of health, and working to think about how we as an area agency on aging and our network of providers that we fund through our federal grant program could come together in new ways to begin to address this issue of falls as well as other chronic diseases. And about in 2016, we had an opportunity through a local granting organization, the Margaret A. Cargill Philanthropies, invited us to think about a project that would make a very significant difference, not just in the metro. Their interest is really rural Minnesota, but said, what could we do? What could you do with an infusion of cash, multi-year, think big? I mean, how often does that happen? It is a blue moon opportunity. And we had been working for some years through our small federal grant program, funding evidence-based health promotion, chronic disease management services. And we'd also been watching this conversation about Medicare and the interest in the social determinants of health and changing Medicare policy to allow particularly Medicare Advantage plans to pay for services that were health related, but not necessarily medical services. And so we now have opportunity in law. I see Ken standing up. We have opportunity in law for health plans under Medicare Advantage to pay for benefits, either for their entire plan population or for certain members of their plan with certain diagnoses or conditions. And so basically we developed a network of providers across the state, mostly nonprofits, but now not all, and trained them and are serving as the hub, a contracting hub, a marketing hub, a data hub, and paying them to deliver fall prevention services through our network that we call Juniper. We have contracts with 4 health plans. They serve people who are duly eligible for Medicare and Medicaid, and we are in conversation with health plans about moving this kind of work into Medicare Advantage plans. We will serve 7,500 people in Minnesota this year. Registration is at an all-time high. And so when we work together, when we collaborate across the state, across a variety of sectors, plans, providers, county public health, nonprofits, aging organizations, we can make something really big happen that I think has some potential for having a population health impact. So I'll end there.
We worked out a very complex system up here. If I stand up, that means wrap it up. Thank you, Dawn. That was great. Let's just move down the line here, and Lisa, please go next.
Thank you very much. Lisa Spenstead. I work for the City of Minneapolis Health Department in the topic of environmental investigations for blood level, which is a fancy way of saying lead poisoning. A lot of people think that we should be over lead poisoning, right? We banned lead out of gasoline decades ago. We banned it out of paint decades ago. But why it was very successful with that ban to remove it quickly from the air, it did not remove it from the home. And in Minneapolis, 75% of our residential housing had that first coat of paint, was lead paint on those houses. And as housing deteriorates, as we move through time, paint continues to deteriorate. So you may put a coat of latex paint over it, but that bottom layer is still delaminating. And we had a real good example this past year of how quickly lead poisoning happens and bounces back on high statistics. So we had a nice trajectory of going down and reducing blood lead levels year after year after year in Minneapolis. And then COVID happened, and people didn't go into the doctor in 2020. Lead poisoning rates plunged, not because children weren't getting poisoned, but because they weren't being identified. 2 years later now, we have over 100 children in Minneapolis lead poisoned. We haven't seen that high a level for 4 years. And we were, as I said, we thought we were making good progress, and then we see how critical that infrastructure is to get children tested at the right time. And more than just an individual child being poisoned and brain damaged for life as a result of lead poisoning, we see a bigger impact on families. Because the child didn't get the in 2020 to get tested when they were 2 years old, now they're 4, and they went in for their doctor visit, and that lead poisoning was caught. But their sibling, who is now 2, also is lead poisoned. So we are seeing more children in one family being poisoned as a result of some of these delays. So, one of the prompts they gave us to talk about this was regulation versus education. And we've tried to educate up and down and everywhere about lead poisoning. And a lot of people are knowledgeable and act quickly about it, but you cannot argue with a toddler. If that environmental poison is accessible, that hand-to-mouth behavior, that's how babies are programmed to learn about their environment. It happens so quickly, and we're not talking paint chips, we're talking dust. Because when you open and shut those windows, it erodes that paint, and that dust becomes available to those little sticky fingers. And when I give these presentations in PowerPoints, I trot out all these lovely slides that show the candy in windowsills, the toys, the nooks, the cereal bowls in window wells, because children love to look out windows. And in Minneapolis, we have these lovely 3-season porches in a lot of the rental housing. And it seems like a very safe place to let your children or toddlers play. They can't escape, it's just all windows out there. And it was probably painted with paint that is 40% lead. So when that starts to deteriorate, a very small crumbs of paint that can get into a child's mouth, they're just so accessible, and the level of toxicity is so high. And one of the things we were asked to talk about is the seasonality. You wouldn't think lead poisoning would have a season, but it does, because 30 days after the windows go up, that's when we see lead poisoning rates go up. 30 days after the windows have shut, we start to see a drop off. So it is, and that happens nationally, not just in Minneapolis. You can look at the rates in other urban areas, because lead poisoning tends to be concentrated in urban areas, but it's not limited to that, because there's old houses in all small towns across the cities. It's also a striking environmental justice issue. 75% occurs in rental housing, which tends to people of lower income are often renting. 80% are BIPOC. And that's so striking in Minneapolis. If you line up poverty and rental and where the children live, it's all the same thing. And so that's why the regulation of looking at the housing and making sure paint is intact is so important. But you can have all the regulations you want, but if they aren't enforced, then you might as well not have the regulation. And so one of the things that we're trying to address the lead poisoning is we've started a very aggressive program of inspections, where it's when we're licensing rental property, we're having lead inspectors, health inspectors go in and look just at the paint, because it's very hard for inspectors to look at everything at once, and it's such a finite, it's such a niche to look just at the paint, to take the time to open every window and look at the back of the window sash, because there's 3 surfaces that are going to poison your children in a house usually, at least in Minneapolis housing. It's a painted floor, because that, and often that's on an exterior porch, but we also see that in some kitchens and bedrooms. It's going to be the windowsill, because that's at mouth height, and about 10% of the housing of the windowsills we test were painted with lead-based paint. That's direct ingestion when you have a child teething on that windowsill. And when you open that window, we call that the window trough, because when we started putting screens on, combination screens on houses, everybody stopped maintaining the back of the window sash. So that paint is literally just falling off into the window trough, where it's so accessible to small children. We need to stop using children as lead paint detectors. The system was designed to respond because there were, 20 years ago there was an overwhelming crisis. We had over 1,000 children a year were being poisoned in Minneapolis with lead, and the system was designed that we respond when a child's poisoned. I think we're trying to move past that to getting ahead of it and identifying those hazards and correcting them before a child's poisoned. There are HUD grants out there that help to afford people to replace the windows, especially in rental properties, because they turn over so quickly. You can have many children poisoned in one property versus a single family home where somebody raises a family there. Then there's only one opportunity. In rental properties, there are many opportunities. So it makes more sense to remove the hazards completely from the property by replacing or encapsulating or enclosing the hazards in those areas that are most accessible to children and where we have identified the hazards time after time of where they are. It would be difficult to remove all the lead from properties because they painted everything with lead paint. Your bathroom walls, your kitchen walls, because it was a nice durable paint. And also we see it in the outside homes. So when you're looking where your children are playing, the general yard in Minneapolis will have about 300 parts per million of lead in the dust. So we want to keep ground cover up. But right next to the house, that's it's not uncommon to see 10,000 parts per million. So that's where it becomes important to mulch next to your house, keep ground cover up, because children move like lightning when they want to grab a handful of dirt and pop it in their mouth. The other area that we work in a lot is asthma. And so for me, asthma has a lot to do with indoor air quality. Oh no, already? So for asthma triggers inside a house, it's animal dander, it's insects, it's mice, especially in Minneapolis. So tightening your home and keeping those things, those pests out, and mold is a big issue. So keeping your home dry on the surfaces, and we have wonderful programs that will come and visit your house and bring you the products that will help, like mattress covers, pillow covers, HEPA air cleaners, and allergen vacuums. Those simple tools can really help a family with asthma to get their child have a good night's sleep so they can go to school the next day, and then they will wrap up.
The system seems to work pretty well. Thank you, Lisa. Let's go to Amanda next.
Thank you. So to echo what Dawn started with, our home should be a haven, and that's where we should feel the safest. And for most people, that's accurate. We feel the safest in our homes. When it comes to fire, unfortunately, that's where you're most likely to experience a fire in your lifetime. As far as fire deaths, right now, we've already had 34 fire fatalities this year. Last year, there were 67 Minnesotans who lost their lives in fire. And so we've seen this gradual decrease over time of fire-related deaths, but we've plateaued. And if we look at the last 5 years, we're actually trending upward in fire fatalities in our state. And so those home hazards, again, are your biggest risk. 40% of our fires are related to cooking, something that we come together around and enjoy as families, but it's also causing the most fire incidents. So unattended fire cooking is the #1 item in that cooking category. We're all so busy out on social media, checking on the kids, doing laundry, doing all our things, multitasking. Don't multitask when you're cooking. An unattended pot is going to be setting you up for a disaster. And then combustibles too close to the stove and the accidentally turned on or left on burner are those top 3 within the cooking fires that we see. I've seen YouTube videos where the excited puppy jumps up on the stove, turns on, and starts a fire in a home caught by like a Ring camera or something like that. So if you have those knobs on the front, good to get those safety locks on there, even if you don't have little kids around, to prevent that. And so, like I said, 40% of our home fires happen with cooking. So that's where our biggest cause of fires. Biggest cause of fire fatalities is smoking materials. Smoking fires count for 3% of our fires in the state. #1 killer in fires. And so very disproportionate. This year alone, we have seen a number of deaths related to smoking on oxygen over and over again. And the victim is so intimately involved with that fire, it is really hard for them to survive when they are smoking on oxygen. So a big message to get out to people is to quit smoking if you're on oxygen. Then kind of in total, our fire departments across the state, most recent numbers respond to 15,000 fires. And of those 15,000 fires, 7,000 of them are structure fires. And the leading location for a structure fire, 1 and 2 family homes. And those are the homes that most fire departments are never going in. Most people don't like government knocking on the door. Hey, I want to inspect your house. So that's a property that generally isn't inspected, maybe during a sale of a home, but I have seen homes where newly purchased home still doesn't have smoke alarms, has out-of-date smoke alarms, missing some of those critical safety features. Right behind 1 and 2 family homes is multifamily dwellings or apartment buildings. And so over and over, we see that high risk for structure fires within the home. So that's kind of the unfortunate news of seeing so many fire incidents across the state. But many fire departments are also looking at the community risk reduction model. So community risk reduction within the fire service, the last probably 5 years, it's becoming a more inclusive and broad topic that we're talking more about. And it's really partnering with agencies and other stakeholders to go to figure out first what the biggest risk is in the community. So conduct a risk assessment. Right now, we're about to unveil our risk assessment tool for fire departments across the state. We've contracted with a company to gather thousands, if not millions, of data points around economic status, fire incidents, anything you can think of related to risk, and have digested it into a dashboard for the fire department to see what their greatest risk. Of course, we're interested in fire, so it's biggest risk related to fire in each individual community. And so somebody in Minneapolis could say, this is the community that is the greatest risk of fire within Minneapolis. Let's target that area and drive down those numbers. The cool thing about this dashboard is that it also has predictive modeling. So today it might be this area of Minneapolis, but in 2 years that could shift over here. And so it allows us to think forward and head off some of those incidents and not just respond to the emergencies. And so in the fire service, we're really focused on the 5 E's of prevention. Oftentimes I hear 3 E's of prevention. For us in the fire service, it's the standard of education, getting out, teaching people about fire enforcement. Of course, my office, we're very much around enforcement of the code, economic incentive, offering those ways to either reduce the cost or a negative economic incentive of finding somebody for non-compliance. Engineering, making sure we have those smoke alarms, CO alarms, sprinkler systems, all of those safety features, and then emergency response. Emergency response is part of that prevention piece, because if we have well-equipped emergency responders, hopefully they are getting there quickly, and then they mitigate faster, and so reduce that impact on that family and that community. So bringing all of those things together to really look at where we can make the biggest impact within communities. Because oftentimes the local fire department is that first call. It's, I don't know who to send when you're on 911, send the fire department, because they will have something. And so we see, the whole scope of injuries, fire, things happening within those homes, and so can make those links with different community partners. And so all of these topics are very relevant to the fire service and working in that community risk reduction model to drive down incident numbers and hopefully get people safer in their homes. As far as enforcement, again, like I said, generally the fire department is not in those single family homes. They might be in the multifamily apartment building. Certainly varies around the state. Some of my colleagues will say that our fire code always has a red cover. And we put it red cover very intentionally because our fire codes are written in blood. Every time we make a new code, it's because of a tragedy. We start doing things in our office at the state fire marshal, again, because of tragedy, because we lost too many kids in school fires. We have a school inspection team, and since they started, fire incidents in schools has dropped dramatically. The Breckenridge Hotel fire at the Stratford Hotel, that was the catalyst for us to start inspecting our hotels and motels in Minnesota. And so over and over we see these major incidents, and that's when we move to enforcement. But if we can get ahead and not have to write code around these tragedies and really educate populations. And so we do public education and try to link with partners to help those incidents around the state. And while technology has certainly helped us in the fire service and made our homes safer, it's really almost in my lifetime really when smoke alarms have really been infused in the homes and become just a standard piece of equipment. People don't even notice that their smoke alarms are there, but hopefully they do, because they do have to maintain them. So not only change those batteries, but they have a lifespan. They're only good for 10 years. And a lot of people think it's just part of the home. I don't have to worry about it. But you need to take it down every once in a while, change those batteries, and also check the date on the back to ensure that it is less than 10 years old, even if it's hardwired. Sometimes that makes it a little more complicated because the wires may not match up with the newer versions, or you might have to get a wiring kit or call an electrician. And so those safety measures have really improved. But I also know when people go to their home improvement store, like Lowe's, Home Depot, whatever, and look at the aisle with smoke alarms, people in my office who are safety professionals go, holy cow, that's overwhelming. And so we've done a great job getting the equipment, but we also have some work to do on teaching what the best equipment is as well.
Very good. So a really good. So hopefully, for those of you in the room, this has helped to promote some questions. So this is a good time to figure out some small group arrangements and to generate some questions for the next 10 to 15 minutes. Then we'll come back and I'll get to as many of the questions as we can for a question and answer period until we wrap up around 9:30. So for those of you watching online, we're going to take a pause on our live feed. We'll come back in about 15 minutes and we'll see you then. This is a good group here in the room. I've got a whole bunch of questions, and sometimes they're multi-part questions, and so going through some of these is going to be really nice. I really appreciate the presentations that the panelists have made. You've shared some data, you've shared some information that's really useful, and you've each brought your different perspectives, which is exactly what we like to see. One question that came up, and I think it's a really good place to start, is to kind of bring us all together on this topic, is this idea of multi-generational living arrangements.
At Trellis, we have observed over the years, or at times been engaged in efforts to support opportunities for older adults to invite someone into their home to help with companionship, to help with chores, home maintenance, and most recently to help with just the financial burden, right, of maintaining a home. And some of these programs have been formalized. There have been public funding for some of them. The latest one that we were aware of was really organized in the private sector, and it was about making the tools readily accessible, being certain that there were the kind of a lease document template, that there was information about what any older homeowner might need to do relative to their city and code, depending on how many unrelated adults would be living in any given home. Sometimes city codes interfere, and we rarely see it get off the ground. I think with the generation of older adults now that are 75, 80, 85, and particularly among white Caucasian older adults, we just don't see it. I think naturally happens families of color happens more readily, and it's customary. There's an expectation that people care for their elders. I'll pass on for others if you'd like to comment.
Sure, we in our office have really spent a fair amount of time thinking about what we've referred to as the sandwich generation, where, all of those generations are coming together, and oftentimes that middle generation is caring for young ones as well as those older adults. And from our data, we've also seen that generally in Minnesota, we've done a good job teaching the kiddos, and so the death rate for fire among kids is pretty low in our state. I would like it to be no kiddos lost in fires, but so we have some work, but that area is actually fairly good. But we find in Minnesota, once you hit age 50, it's not even older adults, that's young still, right? We're vibrant and young at 50, but that's where the risk really starts for dying in a fire, is the 50 plus. And so we've done work around talking to those children who are adults to come together and help prevent those fatalities. So not only 50, but also rural and those aging in place. And so very much a challenge. So coming at it from different angles and incorporate the whole family into messaging.
Can I just make one other comment? I think that we could see a change, right? Because it'll happen by necessity, particularly as we have workforce shortage in nursing homes and assisted living. That families there will not be other options if we don't have the ability for care in assisted living and nursing home because of workforce shortage. So we may see a change because of that driver.
So, Dawn, in your earlier comments, you were talking about your, I forget it was mother-in-law and father-in-law, but how you watch that decline. We see so much that connection between physical health and mental health. And as a person's physical health, where they have an event that happens that it can lead to then further declines in mental health. And I've seen that in my parents' case as well. So for people with chronic conditions and other health risks, are there things that you've seen that have been effective in mitigating some of the risks in the home that we've talked about to overcome the challenges that they may have because of physical health issues?
Sure, I'll start on that one. So with our Juniper programs, they're based on model, form and express small incremental goals to practice those, and to do that in a way with lay leaders who have often experienced the same chronic issue or had a fall, and they're building a connection to each other. And so what we see is both reduction in falls as well as changes in chronic disease. And what's so amazing with these Juniper programs is that we also see people telling us that their anxiety is reduced, their loneliness is reduced, they feel less socially isolated, and they maintain connections with members in their groups, or they are encouraged to reach out more broadly to family and friends in community because they have, they've kind of taken charge, right, in a new way. So we continue to be very excited about these evidence-based programs for their simplicity, their cost, and their impact, low cost, I should say.
I guess I'd like to talk a little bit about respiratory care in homes. Advertisers do a really good job of saying, buy our product, it's going to help you. One of the things that I kind of dislike are the Glade plugins, because these products that are sold to cover up a musty odor does not really address the problems. What is driving that moisture? And mold is a niche organism. It just needs a little bit of moisture in order to be able to grow. And when you just cover it up, you're not addressing the thing that is really going to impact your health if you're reacting because of exposure to mold and mildew. And then you're adding something on top of it, because if you have a lung issue, any particles you're inhaling are going to impact you. And so that's being sold products with all these odors and perfumes, and I can't even garden outside when my neighbor throws the dryer sheets in with their perfume dryer sheets. You know, and then I'm trying to garden next to this, and I'm getting blasted by these chemicals that make me want to puke. So educating people on what's in your home and how you can change things in your home and what you choose to do, and to get at the root cause of things rather than just the surface thing. I can't tell you how many times we get complaints about a landlord who has addressed a moisture issue by painting over the mold. Well, that sheetrock's wet. If you don't remove the moisture source, it's just going to grow through.
So, I'm interested to know how the COVID-19 pandemic has impacted the work that you've been doing over the past couple of years. I think all of you can probably answer that in some way. So who wants to go first?
Well, I had already talked about how it increased lead poisonings in children. How we went about our all the time now, because that's just sort of expected. I think it's highlighted people who have more immunocompromised, that are more fearful of, you know, just the flu or a cold even, that could have impacts for their lives. And they're more comfortable about saying, no, I want the minimum number of inspectors in the house, and I want everybody to mask up. So COVID has changed things in that way, but it has also made people more reluctant to allow inspectors into their homes when it might actually have a benefit to be there.
Similar for our inspectors, although through the whole pandemic, we actually continued all of our regular inspections. The properties that we're required by statute to inspect, of schools, hospitals, hotels, motels, foster care, daycare, all of those things. We did have to pivot a little when there were outbreaks and make sure that we were taking good precautions to protect those that we were serving as well. But much of it maintained the same. But on a national level, the National Fire Protection Association is looking at virtual inspections, and so there is that guidance and movement towards, you know, being able to do a FaceTime to look at the property and facilities or take pictures. And some of our teams have already started to implement some of those ways of doing business. You know, when it's a sprinkler system installed, they just need a picture of some brackets or heads or whatever it is. Snap a picture and send it to me, and then we're able to proceed with projects. And so it certainly has made creative solutions to reduce travel or contact with people to keep everyone a little more safe.
I would say for Trellis, in our work of funding home and community-based organizations to deliver services, it was really the opportunity to say, all right, what could we do virtually, right? So some easy examples where we might fund organizations to provide support groups for family caregivers, those kinds of things became virtual, and caregivers really found that to be very, very helpful. In our fall prevention and disease management program work, the licenses did not allow programs to be delivered virtually, so we were able to work with the licensors and enable them to develop virtual delivery or telephone delivery, which is not on your smartphone, but just calling in for some of the programs. So that's been tremendous, and so interesting then to see a very small organization up in Northwest Minnesota embracing this opportunity to deliver virtually and be serving people all across the state. So that was wonderful to see some of those barriers break down for small organizations. I think we also found ourselves in a new role. I mean, we know that older adults suffered some of the worst consequences of the COVID-19 pandemic, and as vaccines were becoming available, we were very concerned about older adults who could not get out, could not get to a clinic, could not get to a vaccination site because of transportation or language difficulties or trust issues. And so with our deep connections in community, particularly with programs that serve minority and indigenous elders, we worked with our nonprofit community, several Londoners programs that we worked with and others we found ourselves in this position of organizing vaccine clinics and providing the logistics, working with our partners and getting older adults who were at risk of not getting vaccinated. And county public health departments were very helpful as well.
This is actually a good segue into the next question. So beyond just COVID-19, what types of technology or how has technology advanced or supported the work that you are each doing? And what do you see potentially coming in the future from a technology standpoint? All of you can respond to that.
I'll start. We're watching and we've experimented a little bit with technology. For example, for people with dementia, there are these animated pets, kitties and dogs and puppies, and we've distributed some of those through a group of providers we fund that offer caregiver consultation and support. We're watching what's happening in residential centers with robots. I think I was so struck. I work in the dementia space quite a bit, and so struck when a person living with dementia said to a group that was gathered, he said, Alexa is a godsend. It helps me remember what day it is, and so it's just, I think we have to be open-minded about technology. We do know that we've also heard that from some primary care providers that virtual visits for some older adults have actually led to more conversation and reduced some anxiety. And so I think just watching how this plays out and experimenting where we can, as well as getting technology to older adults who don't have it, often for financial reasons. And we're watching that, and we've done some experimenting as well with some federal COVID dollars.
I think COVID taught us all how to work in different ways that we were always told you can't do it that way before, that everything has to be in person. We learned that no, not everything has to be delivered in person, and you can do some inspections virtually, and you can do training virtually. One of our goals was to provide training and guidance on asthma and home triggers, and not being able to go into people's homes because people wouldn't invite you into their homes. But we did get people to sign up and do trainings online. And so it promoted that use of technology that was always there, but it hadn't been pushed because it was kind of easier to do it in person than it is online. And I think that's provided a lot of reach. And I think there's more and more, there are tech tools that are coming online, and technology is being made cheaper, like for home inspections. Moisture meters used to be quite expensive. Now you can get them, under $100 so you don't have to punch holes in walls to find out what's going on. You can just scan things on the surface. So I think it does provide a lot of opportunities to assess the homes.
And similar for us, certainly moving in the way of incorporating more and more technology, that online learning, we certainly embraced it at the fire marshal's office and offered a variety of different code trainings, and people around the state were like, this is great, we don't have to travel and spend as much time in a vehicle as we're going to be at a training, and it's posted, so it's on demand, so it works into my schedule instead of whoever the trainer is. And then broadly across our office and then the fire service, more and more use of drones. Our investigation team, well, they don't have the technology. Sometimes we'll work with partners to do 3D modeling of fires, and so during that investigation, taking all the pictures, and then you can share it with whoever, the insurance company, the homeowner, to see that 3D picture of what the inside of that home looks like. And so there's some really great tools that certainly make our lives easier.
We certainly have seen that at MPHA too, how to do things differently. So how we did, forums like this over Zoom, and how we can do it with people live streaming as well as here in person. So those certainly have had impacts on us. So now we're at the speed round. So in 60 seconds or less, each of you please tell us what are the top 3 messages your organization wants to get out to the people that you work with. Ready? Go.
Get your children tested by the doctors to find out for lead. Look and be aware. Lead is very characteristic. 90-degree cracking. A cheap coat of paint is better than nothing. It will lock it down and safe for a while. And install hand railings, because oh my God, people fall all the time.
I would say stay and look when you cook. Check those smoke alarms, make sure they're less than 10 years old, change those batteries at least once a year, and test them monthly. And then finally, while smoke alarms are great, we really need to focus on prevention so that you never have to use that smoke alarm in an emergency. There's simple ways, and sometimes we're complacent about our safety within our home with fire.
I'm definitely not as good at this. I would say just one message, and it might be reach out to your area agency on aging through the senior linkage line, 800 number available to everyone across the state, and tell us what is concerning you. Help us understand your problem or your dilemmas, and we will work with you to try to find a solution.
You all did that very well. Good. Well, as always, the discussion and the questions are greater than the amount of time we have available, and so unfortunately we have to start wrapping things up. I really want to thank each of you. Our panelists did a great job, as they always do, in talking about the issue at hand today. And I've learned a lot, and there are a lot of good pieces of information that we can all take with us. I've heard that regardless of age, background, where you live, safety in the home is a multifaceted issue, many concerns, and there are lots of things that we can all do to make ourselves and those we love be safer in their homes. And so I think it's important that we think about that. Also, I heard that one good thing that came out of the pandemic is we've learned that we can do things differently, and we can do things in ways that we may not have considered before or didn't think would work before. So we've expanded our thinking, our horizons a little bit when it comes to how can we work within our existing structures. We probably have also uncovered some ways in which our existing structures may not be as responsive as we'd like them to be. So what further improvements might we make? I think that's a good thing to think about going ahead. I know in the fire service we've seen a tremendous change in what the fire service does. If you think about a couple of decades ago, where the primary reason that we as a fire service would get called was to put out a fire. Well, today the fire service is more of an EMS agency than anything else. We are deeply embedded in the emergency medical services as first responders, as transporting agencies in some cases. And so we've seen, again, this blending of public safety and health, and so I think that's going to continue. From your perspective as citizens, 911 is a great resource, right? And so that'll connect you to the resources that you need. And as Amanda said, if they don't know who to call, send the fire department. They'll figure it out. And that's a good message to hear. So I think at this point I will say thanks, and I'll turn it back to Ellen to wrap up.
Thank you. That is true. The fire department is very helpful. I think they came when I called when my toddler had a febrile seizure. So they are very helpful on a range of issues. thank you all so, I don't know, I should stay closer. Thank you so much. I certainly have learned a lot, which is the case with every policy forum. Like, I found my CSA, like I remember things I need to do, I get programming ideas. Like, every policy forum is wonderful, and thank you so much. I have a lot of ideas for my personal life and my work, because I work in home visiting. So I think there's a lot of relatable things. Anyways, thank you all so much for coming. Our next policy forum is January 20th and is going to focus on safety and injury prevention in the workplace. If you are not a member of MPHA, I encourage you all to do so. We have a range of different membership options, including we have scholarships as well. Committees are a really great way to get involved. We have policy and advocacy, health equity, membership communications, something for everybody, seriously, which is a wonderful thing about public health. Our annual conference will be in this spring, so keep that in mind. One other thing I'll mention is we are participating in Give to the Max Day on November 17th, so I would encourage folks, if you want to support our programming, our scholarships, MPHA in general, please consider donating to us on November 17th. And thank you all for being here. Have a good Friday.